Let's continue our conversation on therapies by looking at cognitive therapies. Being depressed and or anxious involves negative thoughts and interpretations. For example, if one loses a job, they may determine the reason behind it as being an internal factors such as I'm worthless or it's hopeless. Such interpretations lead to depression. Or in the other example, they lose a job and their interpretation as to why they lost a job could be, for example, my boss is a jerk, I deserve something better. This leads to no depression. So, in the cognitive perspective, the cause of depression are not bad events, but our thoughts about those events. Cognitive therapies practice. Cognitive therapy helps people alter their negative thinking that worsens depression and anxiety. Therapists might suggest other thoughts that the clients could have about their lives, or at least point out when clients jump to conclusions that make them feel worse. Schools of cognitive therapy. Albert Ellis's rational emotive behavior therapy, challenging irrational beliefs and assumptions. Aaron Beck's cognitive therapy for depression, correcting cognitive distortions. Donald Meachenbaum's stress inoculation training, practicing healthier thinking before facing a stressor, disappointment, or frustration. Aaron Beck's therapy for depression. Aaron Beck helped people see how their depression was worsened by errors in thinking such as catastrophizing, interpreting current events as signs of the worst possible outcomes. For example, now that I've made a mistake in my lecture, I failed as a professor, students can't take me seriously, and they can't learn from me. Beck's style of therapy helps clients notice and challenge these errors in thinking. Here are some cognitive therapy techniques. So, below we have the following: the aim of the technique, and then sort of an example. So, we have reveal beliefs. The technique is to question your interpretations, rank thoughts and emotions. Test beliefs. Examine consequences. Decatastrophize thinking. Change beliefs. Take appropriate responsibility and resist extremes. So let's look at these examples. Reveal beliefs. Question your interpretations and rank thoughts and emotions. Explore your beliefs, revealing faulty assumptions such as I must be liked by everyone. Rank thoughts and emotions. Gain perspective by ranking your thoughts and emotions from mildly to extremely upsetting. You can also test beliefs, examine consequences, explore difficult situations, assessing possible consequences, and challenging faulty reasoning. Decatastrophize thinking. Work through actual worst case consequences of the situation you face. It is often not as bad as imagined. Then determine how to cope with the real situation you face. Change beliefs. Take appropriate responsibility. Challenge total self-blame and negative thinking, noting aspects for which you may be truly responsible, as well as aspects that aren't your responsibility, and resist extremes. Develop new ways of thinking and feeling to replace maladaptive habits. For example, change from thinking I am a total failure to I got a failing grade on that paper and I can make these changes to succeed next time. Cognitive behavioral therapy works to change both cognitions and behaviors that are part of the mental health disorder. Using cognitive behavioral therapy, people with OCD, obsessive compulsive disorder, are led to resist the urge to act on their compulsions as well as to learn to manage obsessional thinking. This is the most commonly practiced and thoroughly researched forms of psychotherapy. For people with OCD struggling to resist giving in to compulsions, such as the need to check 3 times to make sure a door is closed the right way, people with OCD use compulsions to reduce anxiety, even if they know that the actions don't make sense. There is exposure and response prevention. This involves being in the situation that would trigger the compulsion, but doing something else instead until the anxiety subsides. Some other types of therapy. Family therapy. Having a session with the whole family at home or in the office allows the therapist to work on the family system. That is, the family's patterns of alliances, authority, and communication. A related modality is couples or marital therapy. Group therapy assembles about 6 to 9 people with related needs into a group, facilitated by a therapist to work on therapeutic goals together. The benefits include less cost per person, more interaction, feedback, and support, and clients realize others share their problems and they are not alone. And then there are self-help groups. Self-help groups are led by group members instead of a therapist. They can be much larger than group therapy with less interaction. The focus is more on support rather than on working on goals during the group session. So comparing modern psychotherapies. Psychodynamic. The presumed problem is unconscious conflicts from childhood experiences. Client-centered. The presumed problem is barriers to self-understanding and self-acceptance. For behavior therapy, the presumed problem is dysfunctional behaviors. For cognitive therapy, the presumed problem is negative self-defeating thinking. And for cognitive behavioral therapy, the presumed problem, self-harmful thoughts and behaviors. And for group and family therapy, the presumed problem, stressful relationships. So the therapy's aim in psychodynamic, to reduce anxiety through self-insight. Client-centered aim, enable growth via unconditional positive regard, genuineness, and empathy. Behaviors therapeutic aim, relearn adaptive behaviors and extinguish problem ones. Cognitive aim of therapy, promote healthier thinking and self-talk. Cognitive behavioral therapy's aim, promote healthier thinking and adaptive behaviors. And the aim of group and family therapy, heal relationships. Therapy techniques. In psychodynamic, the technique can involve interpreting patients' memories and feelings. In client-centered, listen actively and reflect clients' feelings. In behavior technique, using classical conditioning via exposure or aversion therapy, or operant conditioning as in token economies. A cognitive technique, train people to dispute negative thoughts and attributions. A cognitive behavioral technique, train people to counter self-harmful thoughts and to act out their new ways of thinking. And a group and family therapy technique, develop an understanding of family and other social systems, explore roles, and improve communication. Using research to help ensure effective therapy. Using client perceptions, therapist perceptions, regression to the mean, outcomes or symptom improvement, comparing treatment to no treatment, comparing treatments to each other, matching the treatment to the disorder, considering research along with clinical expertise and client characteristics, considering treatments with less research such as EMDR and light exposure therapy, common elements of effective psychotherapy, culture, gender, values, and preventing disorders. How do we know if therapy works? There are different measures of the value and effectiveness of psychotherapy. Whether the client is satisfied, whether the client senses improvement, whether the therapist sees improvement, whether there has been an observable, measured change in initial symptoms. Problems with some measures. If clients perceive an improvement, are they trying to justify time spent on therapy? If therapists see an improvement, are they seeing only their good outcomes? If research shows good outcomes for most clients, would they have improved anyway? Studying treatment outcomes. To track the effectiveness of an intervention, use a control group not receiving the intervention or even a placebo group. To measure effectiveness, use objective, observable measures of symptoms rather than relying on client or therapist perceptions. Understanding outcome data. If we find that even people in a control group, for example on a waiting list, showed improvement, is therapy a waste of time? These two curves in this graph demonstrate the numbers behind individuals who receive treatment and those who do not receive treatment. What they tell us by looking at these two curves is the average untreated person's is lower based on a poor to good outcome than the average psychotherapy client, which is have a more of a positive or good outcome. About 80% of the untreated people have poorer outcomes than the average treated person. So people are more likely to improve with treatment. Results of outcome research. Which forms of psychotherapy work best? To some extent, it depends on the mental health problem being treated. So for depression, we see cognitive behavioral and psychodynamic therapy seems to work best. For anxiety, cognitive behavioral therapy, psychodynamic therapy, and exposure therapy. For phobias, exposure therapy and behavior conditioning. And for bedwetting, the best one would be behavior conditioning. Using outcome research in therapy. Evidence-based practice refers to the use of outcome research about the effectiveness of different techniques to select therapeutic interventions. Clinical decisions are based on more than just outcome research. So clinical decision making takes into account the following: patients' values, characteristics, preferences, and circumstances, one's clinical expertise, and the best available research evidence. Evaluating alternative therapies. When new cures emerge, they are often promoted with testimonials. The problem: we don't know if those cures were really caused by the intervention. In addition, we don't know how many people received no benefit from the intervention. The solution: controlled studies with random assignment to non-intervention conditions. The challenge: making sure the interventions are performed by people trained in that area. We have eye movement desensitization and reprocessing, EMDR. In EMDR therapy, the therapist attempts to unlock and reprocess previous frozen traumatic memories. The therapist waves a finger of light in front of the eye of the client in order to integrate past and present and left and right hemispheres. Some studies show EMDR is effective and some do not. Studies which did not show effectiveness were critiqued by the founder as being done without adequate training in EMDR. Is this a valid critique of the research? Research suggests that the effectiveness of EMDR, even when it does work, may not depend on the eye movement technique. Light exposure therapy. Research supports the idea that daily exposure to bright light, especially with a blue tint, is effective in treating the depressive symptoms of seasonal affective disorder, or SAD. What do effective psychotherapy styles seem to have in common? Hope. Therapists assume the client has resources that can be used for recovery and that improvement is possible. A new perspective. New interpretations and narratives from victim to survivor can improve mood and motivate change. The relationship. Empathy, trust, and caring provide an environment for healthy growth. The successful working relationship between therapist and client has been called the therapeutic alliance. Psychotherapy also may offer 1. A safe place to explore feelings and ideas in the self. 2. A source of ideas and options for behaving and seeing things differently. 3. Exercises in behavioral, cognitive, and emotional change. 4. Affirmation for who you are along with support for change. And 5. A source of challenge and enrichment to support neural growth and integration. Culture and values in psychotherapy. Therapists who differ from clients in beliefs, values, cultural background, controversial style, conversational style, and personality. The way to serve diverse clients. Therapists should be receptive, respectful, curious, and seek understanding rather than assuming it. The therapist and the client do not have to have similar backgrounds for effective therapy and a good therapeutic relationship. It is more important to have similar ideas about the function and style of therapy. Research shows that therapists who are curious and open are more effective at working with clients from different backgrounds than therapists who study a great deal of diversity material. Selecting a psychotherapist. How do you choose a psychotherapist? Specific training and experience in the area of your difficulty may be more important than the general type of license. What is most important is whether you and the therapist are able to establish an alliance. Some of this is trial and error. If problems arise, you can try working it out, but switching therapists is okay. Therapists and their varied training. Psychotherapists do not equal psychologists. Psychologists, PhD or PsyD, do therapy plus intelligence and personality testing. Psychiatrists, MD or DO, prescribe medicine and sometimes do psychotherapy. Social workers, a Master's of Social Work, MSW, as well as counselors, nurses, and other professionals may be trained and licensed to diagnose and treat mental health disorders. Better living through chemistry and other brain interventions. Psychopharmacology, antipsychotic, antidepressant, anti-anxiety drugs, mood stabilizers, how some medications work at the synapse, ECT or electroconvulsive therapy, magnetic stimulation, deep brain stimulation, psychosurgery, and therapeutic lifestyle change. Biomedical therapies. Interventions in the brain and body can affect mood and behavior. Biomedical therapies refer to physically changing the brain's functioning by altering its chemistry with medications or affecting its circuitry with electrical or magnetic impulses or surgery. Psychopharmacology refers to the study of drug effects on behavior, mood, and the mind. Here are some types of medications. The antipsychotic, what do they do? Reduce symptoms of schizophrenia, especially hallucinations. How do they work? Blocking dopamine receptors. Side effects: obesity, diabetes, and movement problems. Anti-anxiety medicines, what do they do? Temporarily reduces worried thinking and physical agitation. How do they work? By slowing nervous system activity in the body and brain. The side effects: slowed thinking, reduced learning, dependence, and withdrawal. Antidepressants, what do they do? Improves mood and control over depressing and anxious thoughts. How do they work? Increased levels of serotonin, sometimes norepinephrine, at the synapses. Possible neurogenesis. Side effects: dry mouth, constipation, and reduced sexual desire and/or response. Inhibiting reuptake. Many medications increase synaptic neurotransmitter levels. They stop the sending neuron from taking back its chemical messages before they are received. So as we've talked about in previous classes, the idea is that the axon, the terminal branch of axon, releases the neurotransmitter that travels across the synapse to the receptor sites of the receiving neuron. But then after it sends its message, after it's been received, they reuptake or reabsorb that neurotransmitters. The drugs such as serotonin, okay, or the drugs like Prozac will block the serotonin reuptake back into the axon, basically allowing the serotonin to remain active longer in one's brain. Mood stabilizers. What do they do? Reduce the highs of mania as well as reduce the depressive lows. How do they work? They're still under investigation. Side effects: various. Blood levels must be monitored. ADHD stimulants. They help control impulses and reduce distractibility and the need for stimulation, including fidgeting. How do they work? Increased levels of effects of dopamine in the synapses. Side effects: decreased appetite. ECT, electroconvulsive therapy. Electroconvulsive therapy, ECT, induces a mild seizure that disrupts severe depression for some people. This might allow neural rewiring and might boost neurogenesis, the growth of new neurons. So we can see the person lays down and they have a system that allows the shock to be delivered that hopefully will aid them in getting out of their deep depression. Repetitive transcranial magnetic stimulation. Another option for repeated deep brain stimulation using implanted electrodes. Like ECT, these techniques may disrupt depressive electrochemical brain patterns. Psychosurgery. A lobotomy. A lobotomy destroys the connections between the frontal lobes and the rest of the brain. This decreases depression, but also destroys initiative, judgment, and cognition. Microsurgery might work by disrupting problematic neural networks involved in aggression or obsessive compulsive disorder. Therapeutic lifestyle change. We can indirectly affect the biological components of mental health problems. Exercise can boost serotonin levels and reduce stress. Changing negative thoughts can improve mood and even rewire the brain. Mental health problems also can be reduced by meeting our basic needs for sleep, nutrition, light, meaningful activity, and social connection. Preventing psychological disorders. Some people show a trait of resilience. They survive stress without developing mental health disorders. Some traumatized people have post-traumatic growth, finding strength and a greater appreciation for life. Community psychologists and social workers work to reduce the risk of mental health disorders by building healthier environments with interventions such as support programs for stressed families, community programs to provide healthy activities and hope for children, relationship building communication skills training, and working to reduce poverty and discrimination.